And there's Dr. Zender.
Great. Good morning, Brian. All right. I suppose we may end up backed up against time here, and we do have an 11 a.m. Mountain Time hard stop. So I'm going to get started, and others can join. And I'm going to spend a couple minutes reading here because this is sort of the official beginning of these board meetings. I'm Perry Fine, chairperson of the Cannabinoid Product Board, and I'm officially bringing this board meeting to order. It is, we'll say 9:02 a.m. Mountain Time, the 14th of December, 2021, our last board meeting of this year. This meeting is being held virtually and is hosted by the Utah Department of Health, the Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded, as you just heard. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Written minutes will also be prepared of this meeting, and approved minutes will be posted to the Utah Public Notice website no later than 3 business days after the board approval. We will also be taking roll, and actually I will turn that over to Melanie to, she doesn't have to do this loud, just make note that the roll is of the board members are being taken, and the current board includes myself, Jennifer Norris, Matthew McGiff, and Jennifer Norris and Matthew McGiff are sitting in today. Their official start is next month at the beginning of the new year. Dr. Ed Red, who will be celebrating in a moment, this will be his last meeting, and you'll hear what the extraordinary work that Dr. Red has done on behalf of this board over the last few years. Also on the board is Dr. Catherine Carlson, Lauren Heath, and Brian Zender. We have members of the Utah Department of Health with us as staff and leadership. Dr. Sarah Woolsey, who's the director of the department's Division of Family Health and Preparedness. Rich Oborn, who is the director of the Center for Medical Cannabis. And sometimes we do have our counsel with us. I don't believe counsel is with us today, but we'll make that a welcome if she does come. We do welcome any visitors to our virtual meeting at this time. This is a public and open meeting. We believe in and follow full transparency. If you're logged in by phone, Melanie, at the close of this introduction, will ask you to introduce yourselves. Otherwise, your identity will be noted. Please type your name in as a comment if you have a comment, or state your name now if you are by phone, so we can all know who you are. If you're participating as a visitor, and I see we do have some visitors and some well-recognized visitors at that, and I fully welcome you, and this is just delightful to see you here with us. If you do have comments, we've got a chat function as well as a raise your hand function. I believe everybody's probably very familiar with this at this time. We'll do the public comment section at the end of the meeting. So you're gonna have to sit through a lot or put yourself on mute and do other things until that your issue of interest comes up. I'm going to, recognizing today that we do have some areas of significant interest in import, we will leave ample time. I'm going to try and close down the agenda at about 20 minutes of 11 Mountain Time, so we really will have plenty of time to have discussion. I'm also planning on this item to announce publicly that we will rearrange the agenda so that the discussion regarding Delta 8 THC will occur as the final item, because I believe that's probably the one of most interest for discussion, and it will be then fresh on everybody's mind, and we'll have some continuity in that discussion. As a courtesy to everyone participating, please mute your lines, your phone or computer, until such time as you're asked to address the group. Board motions and votes will be recorded in the minutes. And now we will proceed with the agenda. And yep, that took 4 whole minutes, which once again, everybody emerged from that state of suspended animation, and we'll proceed with the meeting. We always start with a welcome, and I do wholeheartedly welcome you all to this meeting. And we will start with a motion by board member to approve the October meeting minutes that have been distributed well over a month ago. So hopefully reviewed and refreshed in your minds.
I move approval.
Dr. Zender moves to approve. Is there a second?
Second.
Thank you. Dr. Smith, I think I omitted you in my roster. I sincerely apologize. Ladies and gentlemen, this is Dr. Misty Smith from Department of Pharmacy here at the University of Utah, a very well-established researcher and also one of our newest members on the board. So welcome, Misty. Thank you. Any discussion or corrections from the minutes before we vote? Okay. We'll do this as an assent vote. So if any, I'll assume all in favor unless I hear a negative response. Okay, board meeting have been, the board minutes have been passed. And now I'm going to turn over to Sarah Ponce, one of our staff members and a very valued member of our group from the Department of Health, to introduce those two esteemed individuals who will be joining us officially in January. Sarah?
Thank you, Perry. For those of you who don't know, I'm Sarah Ponce. I'm the Senior Registered Nurse for the Center for Medical Cannabis. And I'd like to invite you all in providing a warm welcome for our two new board members. First is Dr. Matthew McKiff. He's a family medicine doctor that practices in St. George, Utah, and is part of the Intermountain Medical Group. Next, we have Dr. Jennifer Norris. She is an internal medicine doctor that practices in Salt Lake at the Granger Medical Clinic, where she also sits on the board of directors. So thank you both for joining us on our board.
I'm scrolling. Thank you very much, Jennifer. Sarah, I'm looking to see if we have Dr. Red on with us, and I do not see him. Ed, am I missing you somewhere? No, Ed's not here. I guess
I just saw his name on there. There he is.
Are you there?
Yes.
Let us all hear your voice.
I'm here. Sorry about that. Sorry.
Okay, no, Ed,
I spent most of the night in jail, so I'm kind of like sleepy this morning.
I don't know if you're kidding or serious, but we won't ask you to comment further. But I do plan on I don't want to embarrass you with these comments. I know you're a pretty humble guy, but you know, you have been an extraordinarily valuable member to this group. In fact, getting us organized and together from the inception. This board started getting itself organized well before the inception of the program officially, clinical program getting rolled out, which was 2 years ago, March, coincidentally with the notification that COVID-19 was amongst us. So it was sort of a crazy rollout in the month of March 2020. But it's the program has been well established and in fact has proceeded amazingly smoothly. And Dr. Red has been largely responsible for a lot of the efforts, especially in meeting our legislative mandate to provide deep background information that's accessible to the public and to professionals through our web portal. The Cannabinoid Product Board portal that's also attached to the Department of Health portal, and in that provides really a fairly comprehensive education on the pharmacology of cannabinoids and history and so forth, and has been the launch point for the work we've done over the last couple of years in taking a deep dive into those conditions that the legislature established as being qualifying conditions for the medical cannabis program here in the state. So Ed, sit down, stand up, take a deep bow. We know you're not going to fade away. You're just going to continue to help inform us. And on behalf of everyone who has had the opportunity to work with you, thanks beyond measure.
Thank you. It's really been a really good process. I've really enjoyed it, participating in it, and I'm just I think that the Cannabinoid Product Board has done a really good job trying to put together some useful information for, qualified medical providers and the public too, for people that are interested. So I think it's been a good process, and I think it's a lot of people put a lot of input into it. And it's been a good effort, but I don't know, I've really enjoyed it. So thank you very much. I really appreciate
Say, Ed, we have some national and in fact internationally renowned and known experts in the field at this meeting, and I would like you to spend just a minute or two describing your practice. It's a really fascinating type of practice. You are a service-oriented guy. You do great work on behalf of the constituents. You were in fact a member of the legislature, so you did have constituents, but now you're back to practicing and describe your practice as well as your experience with the medical cannabis program on behalf of your patients. Just to give us that sort of sense of
Sure.
how you've experienced this as an actual practitioner.
So, first off, I'm trained in internal medicine, board certified in internal medicine, but about 15 years ago, I joined the health department, and part of their mission was to try and help fill in gaps in the community where service wasn't being provided. So about 13 years ago, I was mentored basically by several psychiatrists and started, doing mental health prescribing as an internal medicine physician, which is internal medicine is challenging, but man, psychiatry is really, really challenging because you really don't know what's going to happen until you do it. Oftentimes when you're treating people with mental health problems. But during that process, I encountered numerous people with lots of different mental health problems. And I still had the internal medicine side of my practice about half time. And I had a number of patients that reported to me some beneficial effects from cannabis as far as dealing with pain and things like that. But I also had a bunch of people telling me some really negative stuff that happened to them with cannabis, whether they were trying to use it medicinally or whether they're trying to use it for recreational purposes. During this whole time, I was also working in the jail, as providing mental health and physical health care in the jail during the last 15 years. And that's been a real extreme learning experience because the inmates tell me all sorts of things that other people don't tell me because they haven't had the experience. And so I've had a lot of, during my interviews with my inmates who have mental health problems, a lot of them tell me about the adverse effects they've had on cannabis and why they stopped using it and all this sort of thing. So I kind of have that perspective. And then I've had some chronic pain patients, people with chronic problems with neuropathy that have told me that it helps them. And they hate getting high. So they really try to avoid, they don't like being high on cannabis. They try to avoid things that make them high. So there's been a lot of interactions with people that have used it both recreationally and, in a medicinal manner. And to me, it's been a really good learning experience to have seen both sides of that. And then I've also seen a lot of people who are adults who started using cannabis when they were teenagers. And I've seen the catastrophes that I think I can't prove. I mean, causation is always difficult to prove, but the repeated associations plus the backup of what the literature shows on this tells me that we shouldn't be using this, this lightly in people who still have developing brains. Little kids that start using when they're 8 years old or 9 years old and use it daily often have a different trajectory in their life than people who don't. That's been my experience. I've seen the benefits it's had in some people's lives, but I've also seen the harms. And so I kind of have a lot of respect for both sides of that. That's been my experience.
Thanks very much, Ed. And once again, a sitting ovation for your wonderful and continuing service to the state. And I do apologize if you're hearing a little background. I'm visiting my grandchildren here in Denver, and
no problem.
As grandchildren are boisterous. Talk about developing brains. Anyway, we're now going to just spend a moment or two. It's sort of boring housekeeping stuff, but very necessary. Talking about the year going forward, how we're going to meet. Over the last 2 years, we have been meeting virtually. We did meet in person prior to that, and there's something that happens in person that just doesn't always happen over Zoom, although I think we're actually adapting more and more so that there is more free flow of discussion and conversation. But that person-to-person stuff is it's emergent. It's hard to describe, but when it happens, it's a wonderful thing. And I was very hopeful and probably overly optimistic that we'd be into a place where we could safely meet in groups in an indoor setting without risk. But unfortunately, I've got to say that Utah is still struggling with getting things under control. And without going into further detail and somewhat disappointment about that, I think we're going to proceed at least through the first quarter of the year with virtual meetings. And I think we'll plan on monthly meetings just to round out our strategic planning. And there are changes going on within the Department of Health. There are changes that and then influence the Center for Medical Cannabis, as well as the Cannabinoid Product Board, including probably some nomenclature change with the board to reflect not only our legislative mandate, but the work we actually do in evaluating evidence under the rules that have been assigned to us through the legislature about how we should conduct our work. There's also legislative session in Utah going forward, where there will probably be some attention paid to the program and aspects of the program. So I think we will go ahead and plan on a January virtual meeting with our new members in place, and then we'll proceed from there month by month. But let's just continue on with that. I'm certainly open to any other discussions. Dr. Woolsey, Rich Ober, and myself have discussed this. We've gone around the world with different possibilities, but given sort of the state of things from a public health standpoint, I think this probably makes the most sense. Sarah, Rich, any additional thoughts you'd like to share? Melanie, Sarah Ponce, anything from your point of view administratively? And board members, is that our approach is second Tuesday of the month from 9 a.m. to 11 a.m. on Mountain Time. And unless there's a irreconcilable conflict, that seems to work for most people. If there is a problem, let Melanie know, and we'll work that out over the email. And then once again, it's important that we set these so that the public can be aware, and we can get public messaging in the agenda and information out on the website and meet our obligations. All right, let's see. So let me pull to my agenda for just a moment. Let's see. So we plan on, at this point, there are two things that have occurred that are worth discussing before we get into the issue of Delta 8 THC. One of which, in January, in lieu of a virtual meeting, we set up some field trips for the board, where some of us in November went to North Salt Lake and we met with a number of the operational folks for the program. That is, the people from the Department of Agriculture who are responsible for growing and essentially the manufacturing aspect of the program, and as well as we visited one of the laboratories where extracts are purified and etc. And it was a very interesting meeting. There was some good back and forth, and that will take the second swing at the ball will take place in January for those board members who are interested and weren't able to attend the first one. I'm going to sort of share with you what I gleaned from that meeting. This is really for the sake of the board, but it might be interesting to most. I think that we have great allies in very thoughtful operational practices from the Department of Agriculture, and especially from the toxicology side. And I think that it was a good opportunity to meet. We did actually meet face to face in an appropriate environment and all, and get to know each other a bit and have an exchange back and forth about the processes of extraction purification, growing extraction purification, and what kind of chemovars we currently have. One thing that really did strike me was that we as a board have not been probably as filled in as we probably need to be as to what products are actually currently available and how those products are not only recommended, but what happens within the pharmacies. And we do have a pharmacy program here in Utah with registered pharmacists who have expertise and interest in this area, and they provide much of the counseling for individuals who are part of the program. I think that the gap that would greatly improve the program would be to have more immediate access for the board, as well as the public and professionals who are qualified medical providers or otherwise recommending cannabinoid products for individuals who are screened and qualified for the program, to understand what products are out there, both in their formulation, as well as the measured contents of cannabinoids. I was actually very pleased to see that there is measurement, quantitative measurement of not just THC and CBD, but also some of the other cannabinoids that are obviously routinely found in marijuana. But I was also sort of surprised to see that most of the products that are on the shelves, if you will, at the pharmacies are largely THC, and very, very few of them have any substantial amount of CBD and trace amounts of other cannabinoids, to the extent that it's unlikely, certainly in the oral dosing forms, that there's any meaningful bioavailability. In the vaped forms, there might be some more, but it's certainly, we don't have PK data to understand that as of yet. But based upon previous literature and studies, I think one can conclude that. And so we're largely, well, let me take a step back. We look at the recommendations and the information that we provided in our portal, and a lot of this work we did in the early days. And this is where your work was so important. So we made recommendations, not just about on a sort of principles of practice, like start low, go slow, and titrate and monitor and so forth, just good principles of practice, but looking at and trying to impute from the literature some basic dosage recommendations, although that's difficult oftentimes to do for various conditions where we don't have adequate evidence and data, but also ratios, sort of stoichiometric ratios of THC to CBD, recognizing there's many other compounds. And it turns out that we really don't have formulations that very interested recommenders could look at and educate themselves about, and then follow those recommendations with products, nor the public. So I think that this bears further evaluation by the board. And one thing I think that would be very helpful would be to have sort of a hot link between our web portal and the Department of Health, with specificity about what the different pharmacies have as their inventory, both in terms of formulation and dosing. And when Rich Oborn and I had a discussion about this the other day, and we sort of figured out how many clicks it took to find that information from the specific pharmacy and what specific products. It's a lot of clicks. And as well as it turns out, the majority of the pharmacies, they have websites, but they don't have specificity in terms of what their inventory and their products contain. There are some, but far from all. So I think that would be a future discussion that I would like to proceed with in January, and figure out a method by which we can do that, and determine whether that's something we can do administratively and operationally, or whether we need to go back to the legislature to work through that. So that's a sort of my general impression, and I would love to hear what others might have to say about that from the board first, and then if there are any other comments, public comments about that you think would be helpful, please either raise your hand or go to the chat, and Melanie will follow the chat. So, board members, any thoughts or comments? Okay, I do see a note from Christine Stenquist, who is responding affirmatively and positively to that. So thank you, Christine, for weighing in. All right, well, great. So we'll go forward with some more discussion and something actionable that we can go with in January. I'm now going to turn to Rich Oborn again, the executive director of the medical cannabis program, who's been at the helm, gosh, what, maybe up 3 years now, Rich, and to sort of give us a review of the program and its sort of the last year, and what your sort of insights into where things may develop in terms of utilization, access, those sorts of things going forward. And also just to make note that we did provide, as the law requires, a written annual report to the legislature via the Health and Human Services Committee in November. Unlike past years when Ed and then myself have given oral reports, the Health and Human Service Committee agenda was overloaded, I guess, this year. And so we did not have an opportunity to give an oral report. I'm hoping that we will go back to that process next year, because I do think that's actually having some oral give and take is very important for the Health and Human Services Committee to report back to the legislature at large. So Rich, take it away, please.
Sure. Thank you, Perry, and welcome to the new board members. And we've got just a few things I thought I'd share really quick. Since the last time we met, like Perry mentioned, we did publish our annual reports. Those are all on our website. That was not only for the Cannabinoid Product Board, but it was also for the Compassionate Use Board and the Center for Medical Cannabis. So there's some statutorily required information that's provided in there, number of card holders, number of pharmacies, number of QMPs, and those type of numbers show up in the Center for Medical Cannabis annual report. Also, since the last time we met, we did issue an RFP for an intent to award a license to Dragonfly Pharmacy, and they have an existing pharmacy located in Salt Lake City, as many people know. We've given them an intent to award for a location in Price, Utah. So we're excited about that opportunity that will increase access for people living in Southeast Utah. And that will be something that opens up during 2022. And so that'll be the 15th medical cannabis pharmacy location in Utah. In addition to the physical pharmacies, as the board members likely know, but as a reminder, there's also home delivery, and more pharmacies are beginning to do that. It's been going on for almost a year now, and we do expect it to continue to grow as home delivery becomes an even more popular method of order for many patients. A few things that are upcoming for the program. There will be the extension of the first period of registration for medical cannabis card holders. That's going to be extended from 3 months to 6 months. Coming up here in the next few weeks, we'll make that extension. There's the software change has to go into production, but we're just wanting, before we do that, to coordinate with some of the clinics on making sure that they're educating their patients about that, and that they're prepared to also work with their patients on that new change. But that'll be obviously a big difference for new patients. They'll have their initial cards for 6 months rather than 3 months. Another critical thing that's going on is that we just launched a survey to the qualified medical providers in the medical cannabis program in Utah, who have given us permission to post information about the services that they offer as a QMP recommending medical cannabis on our website. So if they circulate information either in social media or through education materials that are printed that represents to the public that they are indeed offering the service of meeting with individuals and have the ability to recommend cannabis to them, that they would be required to inform us, complete a survey that we sent out, and the deadline to respond is this Friday. They are required to let us know about the fees that they collect. And this is, many of these clinics have very complex fee structures, and some of them are very simple. Some of them accept cash, some of them bill insurance because their visit is for a purpose that is not just cannabis, but it's for general treatment of chronic pain or general treatment of a medical condition that you're able to bill for. So there's a wide range of prices, and the legislature, of course, has wanted us to post a healthcare transparency tool for patients to be able to go and actually compare prices. Each clinic is very different, and sometimes, you know, a provider will spend 15 minutes. Sometimes other clinics spend 30, 40 minutes with one patient on each visit. And so for that reason, there's varying degrees of prices that are charged, but also there are some clinics that just charge an outrageous amount. And we want those clinics to report what they're charging. And we believe that as that happens more and more, those prices should level down, and that'll either put those clinics that are charging a lot of money out of business, or they'll just level down and not charge as much as some of them are. Because there are a lot of clinics that are reasonable in the prices they charge, but there are others that aren't. So this healthcare transparency tool will be an advantage to patients as they make that choice. And it's not just for new patients, it's for existing patients that may have charged or been charged more than they had wanted to be in the past, but that now they want to switch to a provider that maybe doesn't charge as much. So that's one additional tool that we'll launch in January. We're just right now collecting the data to be included in that posting of information on the state auditor's website. An additional item that I think is important for the group to be aware of is that the Department of Health is close to launching the limited medical provider tool in our program, which would allow any MD, DO, PA, or APRN who has a controlled substance license who can prescribe in Utah. This is about 16,000 prescribers that have that ability. They would be able to recommend to up to 15 of their patients. They would be able to recommend medical cannabis, and it would allow them to communicate on a piece of paper this recommendation to a medical cannabis pharmacy, or they'd be able to communicate it electronically in a secure manner to a medical cannabis pharmacy. And we are doing some outreach this upcoming week and next week with the medical cannabis pharmacies to establish exactly how they will accept those and to set some standards to ensure it's done appropriately, that it protects patient information, of course. And also that there needs to be a method that they employ to help verify the identity of that clinic or QMP that is the limited medical provider recommending one of their 15 patients. So we'll be engaging in some outreach with medical cannabis pharmacies, but also a significant piece of this is engaging in outreach with just the regular prescribers out there who are not participating in the medical cannabis program currently, but maybe have an interest after they have learned of some information. They may just want to research it a little bit more, and if they feel comfortable, if they have patients that could benefit, if they believe may benefit from medical cannabis use as a medicine, then they could recommend to this particular patient to be one of their 15 that they recommend to. So we want to make it as easy as possible for those providers to be able to participate in the program, although they wouldn't register with us, they wouldn't pay a fee, they wouldn't have to go through some required training, but they'd still be able to do it to up to 15 of their patients and help those 15 participate. So that we're expecting to launch here in January as well. We tested the software. It's a matter of reaching out to the providers to educate them about how to do it, and then also educating the pharmacies as to how to accept those recommendations. So that's a critical change to the program that we're excited about, that will increase patient access to medical cannabis, and it will keep their they would have the opportunity to keep their primary physician that they've been meeting with potentially for years. If that physician is willing to recommend cannabis to them, it allows them to keep that continuity of care with that particular physician. So we'll be able to share more information about that with the group later on as we communicate with various professional associations and provider groups about this launch of the limited medical provider provision. Let's see. Also, we're very close to contracting with an academic pharmacist who would help support the Cannabinoid Product Board operations and the Utah Department of Health operations. And so that's something that I think will advance our work. The legislative session begins on Tuesday, January 18th. It lasts until Friday, March 4th. So that's coming up. There's a number of items that may impact the Utah Department of Health and Department of Agriculture that I know legislators are considering right now. We've got about 40,700 active medical cannabis card holders participating in the program, and about 810 qualified medical providers. Of those 810 qualified medical providers, about 415 of them are ones that publicly share information on our website. So about half of them are public about their offering of medical cannabis evaluations or recommendations, and about half of them aren't public about it. Also, we just recently improved the lookup on our website. If someone is searching for a qualified medical provider, they can use a lookup that allows people to type in the actual city where they're looking for a QMP. Like you could type in Farmington or type in St. George, and you'd be able to find the qualified medical providers that are registered in that area. And so in the past, it was just organized by county, but this allows patients to be a little more specific about what they're looking for. And we think that's a great development that will just allow patients more power to identify those providers that are able to help them in certain areas. Are there any questions about any of the information I've shared?
You have one in the chat, Rich.
I have a question also.
Yeah. So go ahead. I'll take this one on the chat, and then I'll go to you. So what if a limited medical provider exceeds that limit? What's the objective of the caps? It feels like it's a dive to patient paper mill. So the limited medical provider would not be able to exceed the 15. They would be able to apply for a qualified medical provider registration if they want to go beyond the 15, like over 800 have done already. So Christine, that's what they would be able to do. And you can, if you have, I think some policy differences with that cap, you can consult the legislator. They set the limits, and I'm sure they'd be willing to listen to your thoughts on that issue. Great, Katie.
Just can you talk about what was the basis of shifting from a 3-month to a 6-month card?
Yeah, I think one of the things that I can't speak for policymakers on this, but I suppose there's many factors that were considered, but one of those factors was that patients were, I think, experiencing a burden when they had to go in and meet. In 3 months, they felt like it was just a hoop that they were jumping through, and not, for some patients, they felt like it was just something that I think potentially brought in just more revenue for the providers that were charging too much. That's one concern I think I heard at the time. One reason why they moved it from 3 months to 6 months, what was just they felt like in many cases it wasn't used as a valuable tool for the patient. The providers still do have the ability to meet with their patients as often as they feel like is necessary. It may take time for that particular patient to find the right product. And I think depending on how much the provider knows about medical cannabis, the more, I think, counseling they feel is of value to provide them. And maybe a more frequent visit is more helpful in cases where the providers have more experience to share and to help in a unique case with the patient. Yeah, I feel like that was just a factor that was considered. I think in some cases, patients felt the word was that it was feeling like it was just a hoop they had to get through. It's a quick turnaround, for 90 days. Initially, it was even shorter than that, and then it went to 90. So that I think was part of the factor there. Katie,
I just comment briefly on that. I am a qualified medical provider, and I have recommended cannabis to some of my patients for various conditions. I can tell you that it does take a while to figure out what's going to work for somebody and how well it works, and if they're even going to stay on it. A lot of patients go on medical cannabis, and after trying it for 2 or 3 months or even 4 months, decide it's not helpful enough to justify ongoing use of it. Other people find out that it's quite helpful, and my experience trying to do the every 3-month thing was it was a real stumbling block, because sometimes I didn't get around to filling out my portion of the certification for additional ongoing things, and people would end up going through times where they didn't have, couldn't go to the pharmacy and get it. So I think the 6-month change is a good idea. Just for me, the 3 months was just too short to get anything done. That's been my experience.
Yeah, I can see that, but I just think we're always up against this kind of customer service kind of business model versus, you start someone on a new medicine, 90 days is a long time to see them. It's not in keeping with any other standard in the medical profession, as far as I'm concerned, especially when we know the effects, and the longer you're exposed, the greater the risk is. So I just find that, disappointing.
and that's a good point, Katie. That's definitely a concern of not only you, but a lot of others. And I would just add, I think it's important to keep in mind that there are providers, like with Schedule 2 and Schedule 3 controlled substances, that take the approach of be careful as you begin taking this new controlled substance. I want to meet with you in 30 days. I want to meet with you in another 30 days after that. Let's tweak this a little bit more. There are some providers that approach it like that, who are QMPs. And also there's this added value of the pharmacist. And in the regular retail pharmacies, you don't have as much of an in-depth discussion with patients. A pharmacist wouldn't have that in a regular retail pharmacy, but in a medical cannabis pharmacy, the pharmacists have educated themselves to a point where they know that the patients come to them for recommendations, and they play a more active role in that decision making and recommendation making of what product the patient is consuming. And I know that's not the typical role that a pharmacist plays, but in Utah, there is this additional scope within the medical cannabis program. So I get it, although yes, that went from 90 days to 6 months, but there is added value in Utah, at least, for that patient to go and meet with the pharmacist. and to have that opportunity to discuss what they're taking and over time to tweak what they're taking. And also the physician that they're meeting with can always say, hey, I want to meet with you. And I get it. Sometimes the patient may not be agreeable to that, but you know, it's a discussion between a patient and a physician. Also cost. Some QMPs are going to charge a lot of money for a visit. So it's a difficult thing for people to charge, and often they're not accepting insurance. So I think that's another factor, is if they accept insurance, then I think that patient visit is just more likely because of the fact that it's more affordable. So those are just a few thoughts.
Well, from a standpoint of where we go as a board, I would like to continue this discussion with the aim of not so much focusing on sort of administrative issues, although bureaucratic and those sorts of things, bureaucracy, you know, is a reality. I think the focus we should be taking from a public health standpoint is how to create, I don't know if incentive is the right word, but a motivation amongst practitioners to follow these patients longitudinally, regardless of what intervention, to have a so-called medical intervention, and it is a medical program, without any type of routine follow-up and evaluation of benefits versus harms, drug interactions, drug disease interactions, and be continuously evaluating health outcomes, just is not a good model of public or individual health. So I think that a discussion of how we can develop that, and regardless whether it's a week, 3 months, 6 months, a year, those are hassle factors, and we should eliminate hassle factors both for the professionals as well as the public to optimize the program to determine whether in fact we're doing net good or net harm for both our, you know, the Utah public, but also but especially individuals. We won't get there unless we can inspire longitudinal, long-term evaluation and repeated evaluations and so forth. And along those lines, Rich, I'd like you to comment on, and maybe Sarah Woolsey as well, Dr. Woolsey, one of the sort of ongoing efforts that we on the board, and certainly it's something very important that I've been trying to promote and work with and liaise with research groups at the University of Utah, is a robust database that will allow us to actually learn something from all of this. It's a lot, 40,000 people, adults, there are kids obviously, but 40,000 individuals represents about 2% of the population, of the adult population in the state. And this is an opportunity to learn something very important. And without a robust, well-constructed processes and outcomes database, all this experience will just be dust in the wind, and everybody will be opining, and there will be no certitude about measures. And to do this responsibly, I think we really do need a third party, an objective, independent group to evaluate the outcomes of what we're doing here. So Rich, you know, you and Dr. Woolsey have been meetings, I've been involved in meetings. We're trying to get the legislature to take this seriously. And by serious, I mean, you know, fund it, because, you know, again, opinions are a dime a dozen. It comes down to funding. So would you like to comment on what you think the likelihoods and the timeliness of all this might be?
Yeah, I'll just share a few thoughts. I think there's a chance that we'll see that happen during the next legislative session. It could be that they decide to do it during a subsequent one, but we are hoping that it'll be this session. And I think what's possible is that we may see something related to program evaluation at the beginning, where we're evaluating program success and tweaks that can be made in order to improve the program. And I feel like that may be a good, responsible beginning. In order to do some of the medical research studies, I think we may need to depend on a federal law change in order to allow federal funding to support some of that. So we'll see where we go with that, but that it's just something I feel like in order to make it valuable and substantive, you need a high level of funding in order to make it really valuable to patients when you're doing clinical trials and things. So I think that should be something that we'll see depending on the federal law and if federal funding is able to support some of these efforts. So those are some of my thoughts.
All right. I do see there's some concern on the chat with regards to, quote, forcing people to participate and questions about ethical involvement in research and so forth. Well, certainly anything that's a formal study needs to go through an IRB and in order to assure that patients are protected. But in the construct of a database, the intent would be for this to be anonymized, that there's nobody's being forced to do anything. We just want to understand what are the consequences, how many people are actually, using what and what's being dispensed in what forms for what purposes, with what changes in health status, so that we actually learn something. And there are ways of doing this without that are fully protective of patients, patient rights, which I think we all feel very strongly needs to be done. I think legislating practice of medicine is always a double-edged sword, and in fact something that is often viewed as highly problematic. And so I would hope that that we within the medical community at large, and those individuals, when I say medicine at large, because PAs and nurse practitioners, all those who have contact with patients, would follow and create responsible standards of care. We would never start insulin or an antihypertensive, no less chemotherapy, no less an opioid, no less a benzodiazepine or a psychiatric drug without close follow-up and evaluation of effects. And those kind of practices have largely been inculcated in medicine, but unfortunately there's a breach of those practices often, and those have led to tremendous harms for individuals and the public. So I don't have any great answers in terms of the culture and the sociology of medicine. I would hate to see us cede that to politicians rather than to the profession and act like real professionals. But I think this is a discussion that we should continue and see if we can use this as an opportunity and figure out how to get better at what we do, whether it's a cannabinoid product or anything else that may have a significant impact on an individual's health and well-being.
And Dr.
that's
Fine, just really quick, can
Yeah.
I share a thought?
Absolutely.
I think there's concern from some individuals regarding how information may be shared with other parties, information that we collect that would be used for medical research in the future. And one thing that's critical to understand is that we don't share patient information with a party for purposes of that other party contacting patients. That is not how we operate. The way that we operate, if there's a study that a researcher is interested in doing, we notify the patients of the opportunity to participate in that study. We don't share patient information with the group that is interested in doing the study. The patient contacts the study organizer and says, yes, I'm interested. So there wouldn't be, like I said, any direct sharing of patient information that would then allow a researcher to contact the patient directly. It all would be Department of Health reaching out to the patients, explaining the opportunity if they choose to voluntarily themselves reach out and contact the researcher. So that's a critical tenet that we comply with of the Department of Health that people misunderstand. They assume that we're just sharing patient information, allowing patients to be contacted, and that's never how we operate. We do have a database, and the way that data is used is important to us. We keep it confidential. We run statistics on it. for program evaluation and program improvement. We obviously have our staff that have to assist individuals as they apply for medical cannabis cards and things. It's really important that we have this information in order to comply with the Utah law the way it's written. And it also helps protect public safety and public health as well. So there's a lot of different reasons why it's important that we have a registration. But for those that want to engage in that discussion, you're happy to email the program separately, and we can provide additional information about how you could request that your information not be used for medical studies. You're welcome to email us and make that request, but also that is something that we feel strongly about, is honoring that request if that's made. So anyway, we might need to get on with the agenda, of course, but I just wanted to explain that in more detail.
No, that's very helpful. And again, this is a ongoing process, relatively new program, but 40,000 individuals has doubled since a year ago. So this is a rapidly increasing part of what's now normative in health-related practices within the state. And again, there's a lot of facets to this issue that we could spend a lot of time talking about. But I think the basic concern as it reflects on this board, and I'm only speaking from what the mandate is for this board, is to help inform public and the legislature and the professions about what we know about the implications and the use of cannabis with medical intent. And to that, it's a good segue actually into the next discussion, because one of the requirements for this board in terms of informing the legislature as they go forward with setting rules and processes and all, is that we are largely not restricted to look at anything, but in terms of what we're our obligation in terms of what we are supposed to use as our foundation for providing recommendations, is in the level of evidence is only restricted to what our institutional review board approved human studies. And so the medical cannabis Center for Medical Cannabis and the program exists without those particular requirements, but this board is required to follow that rule set. So I'm not sure that everybody knew that. I was having a discussion with a member of the state legislature, a physician actually, who is very interested in this area, the other day, and he was completely unaware that the fact is that we are only supposed to report on IRB approved studies in terms of informing and making our recommendations. And so I think that's actually a very important thing for everybody to consider with regards to the context of this discussion and this board as we go into the next agenda item, which is on Delta 8 THC as a cannabinoid. And I know there's strong feelings on all sorts of throughout the spectrum of things. And so I'm only going to introduce the topic by saying that we on this board were made aware that in fact Delta 8 THC was being as a cannabinoid product was being distributed through our pharmacies, or at least one of them in the state. And this has come to the attention, obviously, of the state legislature, of the cannabis program, to Dr. Woolsey and Rich Oborn. And in preparing for this meeting, I, amongst some others, dove as deeply as we could feasibly do into the literature to see what the levels of evidence are, not just beyond the pharmacology, but how to understand what applicability there might be as a medicinal product, and are there any IRB approved studies that could shine some light on medical indications, safety, efficacy, et cetera, et cetera. And there was really only one clinical trial that I was able to find that sort of met sort of basic methodological standards in humans, and that was in children. And it's an offside study with regards to nausea and vomiting in a group of kids. This was an Israeli study, and I know the researchers well. These are very high quality researchers, and yet it was an open label study, and with a relatively small cohort. One of I searched as I might for, and I was very surprised to find that there was no inclusion of a statement with regards to institutional review board evaluation approval or anything like it. And so when one of the comments here about ethics, it brings into question, when we're bringing humans into clinical trials, there are standards which absolutely need to be followed to protect for patient protection. And unfortunately, this study did not meet that standard as far as I could find. So I don't have much more to say about it other than that based upon what our researchers currently found on the board, there's really not much to say or put forward to the legislature other than there is no evidence base in human health conditions for which we can make a recommendation about safety or efficacy. I understand there are a lot of concerns otherwise, but from the standpoint of the context of this board with those qualifiers, that's where I think we stand. So, but let's go ahead with a discussion, and maybe Rich, from your standpoint, and maybe Dr. Woolsey, you could give a little background of where things are, and then Melanie, why don't you manage the chat room, and we'll see where we go here.
Yeah, this is Rich Oborn. I'll just be very brief. I think there's a lot of concern across the United States about Delta 8, and states have approached the issue in different ways. Some have put an outright ban on Delta 8, even in the cannabis program. Others allow it just in the cannabis program. And then another group allows it in the hemp program and the cannabis program. So they kind of fall into three groups out there. And I think the approach that I've considered is, it seems that based on information that's been gathered, that there's a thought that it should not be in the hemp program, but there's a question of whether it belongs in the medical cannabis program. And I think with the appropriate standards in place, it's possible. The Utah Department of Agriculture and Food, I think, have some thoughts to share about that, because they've I think taken a deep dive on the issue as it relates to the processing of Delta 8 in some of the labs and some of the use that they found there. And so I'd rely on them for some of that. There are some there is some major caution across the United States about it. I think especially in the black market, if you can't trust the source of the product, it probably shouldn't be a product that you're purchasing. You need to buyer beware across the United States, regardless of where you live. You need to ensure that you know the source of whatever kind of product you're buying. It's not just Delta 8, but it's any of the synthetic drugs out there. Synthetic Delta 8 is one hot topic, but there have been several others that I think in the future that'll come up. It relates to often the synthetic creation of these drugs. So it's important that people just keep that in mind, regardless of where we go. It always goes back to that decision making that individual is making about the product that's purchased. So those are just some of my brief thoughts, and those are my thoughts, Perry.
Okay, Dr. Woolsey.
Yeah, thanks, Dr. Fine. Just a reminder, I appreciate the Cannabinoid Product Board's, guidance that we use the best scientific evidence that we have, IRB approved, nationally recognized studies. So I appreciate the background you gave, Perry. Second thing, just to add on to what Rich was saying, it's not just Delta-8 THC, but it's THC analogs in general. And I would encourage us as a community to keep people safe. We begin to talk about analogs, not just Delta-8. Delta-8's gotten a lot of attention, but we need to be on guard for risks of psychoactive analogs of other forms as well. And then I just appreciate the partnership we have with the agricultural program and our medical program to work this out under Utah's program to keep Utahns safe and to avoid some of the harms that we've seen nationally. Thanks, Perry.
Sure, and thank you. Now, let's see, I would actually like to, in the queue here, I'm sorry, Melanie, I'll just go ahead to sort of take over. Dr. Russo, who is an internationally known expert in the field, so I'd like your comments, followed by Dr. Viner, who is practitioner in Nevada, and then followed by Christine Stenquist, because she has some insight, I think, that she would like to share as well. So, Dr. Russo?
Thank you, Perry. Just by way of background, I'm a board certified child and adult neurologist. I was in practice in Missoula, Montana for 20 years. But for the last 25 years, I've been involved in cannabis research and development. 16 of that was with GW Pharmaceuticals in the development program of Sativex and Epidiolex. Just by way of background on Delta-8 THC, this is a natural component of herbal cannabis, but usually in trace to very small amounts. So it is not inherently dangerous. It pretty much is analogous to Delta-9 THC, but possibly of slightly less potency. As Perry mentioned, it was used in one clinical trial in Israel, 200 exposures of kids who had nausea associated with chemotherapy, no problems, and good efficacy. That's not the problem. The problem is how this stuff is currently made. The reason that we're seeing this profusion of Delta-8 is a dodge to the illegality of many of these products. Technically speaking, under the Controlled Substances Act of 1970, if hemp material is extracted, the material that results from that is illegal. Now, that may or may not have been overruled by the Agriculture Bill in 2018. And the DEA has taken a position that these products are legal, but I think that that is a disingenuous stance and that they really don't want to deal with this. As it turns out, this material is being made from excess supplies of CBD. Basically, there's a glut of hemp material and people are looking for ways to profit therefrom. So the Delta-8 that results may or may not be an issue, but certainly many of us are hearing of people getting into trouble with this material because of excessive dosing. Like anything else, if Delta-8 isn't inherently very toxic, too high a dose will be, just as with Delta-9. The real problem, however, is in its manufacture and the fact that these products are not just Delta-8. They are also invariably composed of Delta-6 and Delta-10, and we know even less about what those do. Although my suspicion is that they aren't inherently toxic, we really don't know. Plus, I'm a member of a group working with the United States Pharmacopoeia on standards for cannabis-based medicine. Among its members are many analytical chemists, and to a person, they indicate that every product they've analyzed with Delta-8 has been contaminated with these other isomers, and additionally other toxic materials, including solvents. So there is no inherent safety that anyone could guarantee to these materials. Now, it's probably well known, I've been an activist in this area. And I believe that people should have access to cannabis-based products, but by the same token, I've been a proponent of safety. And I'd like to commend this committee for the proactive work that you've done and the care that you've applied to this. Certainly my feeling is that these are products that I don't think should be foisted on consumers who really aren't in a position to know the inherent dangers that may apply to them. And I guess with that, I'll stop, but I'd be happy to answer questions if time allows.
Okay, thanks, Doctor. So just a point of clarification, Dr. Carlson, who's a member of our board, reminded me that yes, we do reserve comments outside of the board for the end of the meeting. This really is that period of time. And Katie, what I did was moved this agenda item to the very end, knowing that there would be some individuals who could help educate us as well as have discussion. The priority will always go to a board member who has either questions or comments to make. So let me go back to that, and I apologize if I short-circuited myself here. Do board members who have had an opportunity to review the literature that we sent out have any thoughts, comments that they would like to share before we continue on with the public comments?
I had just a couple thoughts.
Yeah, Lauren, please.
It's related to what we've been talking about, although maybe a little off topic. I just wanted to clarify the point about what the board is allowed to review in terms of the scientific studies. I know initially the law required that it had to be conducted by an IRB, but I thought maybe that we had since updated the law, and now there were 3 different categories of things that we could review. So conducted by the IRB, conducted or approved by the federal government, or conducted in another country but has sufficient scientific reliability or significance. I don't know, I might be mistaken, but maybe we could, after this meeting, double check so we know moving forward about what we're allowed to.
Yeah, good questions, Lauren. I reviewed the language, and I sort of do this on a regular basis because the bill is extensive and requires review, and there's many amendments. Best of my understanding, and why we sometimes go back to council to confer, is because there are amendments made, and it's important to understand what our mandate is. You're correct that it's not just IRB approved studies. It is also studies that are being conducted by the federal government or under the aegis of the federal government, for instance, NIH. In terms of international studies, initially we were restricted to US studies that were IRB approved. That, as of a year ago, was amended to, because there was very limited data coming, within the US, and a lot of studies abroad, and especially there was a lot going on in Israel, which I was somewhat involved in. I think others on this, Ethan maybe as well, know a lot of these folks. And so this was opened up to be more broad, but still with the caveat that these had to be responsibly, from the standpoint of ethical standards, which means IRB reviewed and approved. So that's my understanding. I'm guessing, Rich, you might have, you can either confirm that, or if there's still not consensus on how to read the law, we will get then advice and consent from our council, and we'll bring that to the next meeting. We obviously don't have time to do that now. Rich, am I interpreting this correctly?
Yeah, and if you've interpreted it correctly, how I interpret it, and if there's any specific questions about different studies, people are welcome to send them to us anyway, and we'll review it with that standard in mind. And if it's helpful to consult with an assistant attorney general about it, we can do that as well. But yeah, it just leaves it open to those conducted in another country and those that also, if it's from another country, that there's sufficient level of scientific reliability and significance to merit the board's review. Yeah.
And just to be clear, we can review anything, and we should. I mean, I want to understand what people are doing and thinking about, and how, and look at whatever is accessible to understand and gain knowledge. But in terms of I'm going to be very discerning about what's methodologically sound, and as if, and then from the standpoint of the context of this board, how we report upwards, if you will. That really does have very well-defined guardrails to it, as Dr. Woolsey reinforced. So let's move to Dr. Viner, who's had his hand up patiently. And,
I had one other thing I wanted
oh,
to
I'm sorry, Lauren. Go ahead.
Sorry.
Go ahead, sure.
Really quick, I just wanted to clarify. I mean, I realize our discussion is kind of talking about many different issues with Delta 8. And I don't know that this necessarily falls under our purview, but I just wanted to understand. I mean, I agree with what Dr. Rousseau is saying about, access to Delta 8 that is coming through other channels that could have a lot of adulterants, other exposures, potentially getting access to people that we wouldn't want to have access to it, like children. That is very concerning. But I just wanted to clarify, in the state of Utah, under the Controlled Substances Act, would I believe Delta 8 would be considered a controlled substance. So if it's like sitting in our gas station or whatever, like those wouldn't be a place that should be allowed to have products that contain Delta 8 according to our Controlled Substances Act. Am I correct in this? I'm very much not a lawyer or anything of that nature.
So one critical thing that we need our legislature to do is to clarify the law. There have been some interpretations that the Department of Health has been given, and Department of Agriculture has been given. Department of Agriculture, I know, has spent a lot of time on that issue, and we can maybe share some time with Brandon Forsyth or another representative of the Utah Department of Agriculture and Food on that issue, because I know they've spent the most time on it as they've evaluated it from their end as it relates to a licensed hemp grower and retailer's ability to sell products with Delta 8. Perry, would you mind if we gave a little bit of time while we're on this topic? Lauren, I think, has brought up an important issue that it's important to address. And
I just want
to,
yeah. Well, there's several, sort of organize the discussion here. There's several issues. One is legality. And I think Dr. Rousseau adequately said, this has been sort of punted. Delta 8 THC is a natural product in cannabis, but in trace amounts, and it was very little attention was paid to it up until I think that there was this study, questioning whether it had value medicinally and as an anti-nausea and vomiting drug at a time when early on we were looking at very specific indications where there was maybe some purported benefit to cannabinoid products. Much time has passed with that, and the legality issue has not been clarified per se. The Utah State Legislature is looking to do, I think, just that, and is looking for input and to advise and consent from us amongst others, including patient advocates and so forth. So this is part of that process. But in terms of legality, it's really ambiguous at this point in time, and there is a distinct difference between stuff that's sold in gas stations when nobody has a clue what it really is. It can be labeled as, and that would go for any product that's not within a regulated environment. So that does bring us to you, Brandon, who is taking a lot of responsibility on behalf of the state to to understand what is actually in the products that are available to the public and make sure they're not tainted, toxic, and they are what they say they are, including in the dosages. That doesn't translate into therapeutic benefit. It just means people are knowing what we're getting, and we're not actually exposing people to known toxic substances. So Brandon, please.
Yeah, so as far as the Department of Agriculture is concerned, it is very clear in Utah code that THC analogs are controlled substances, and we've been moving that direction and working with the legislature to clarify that for the public. There has been some more gray area in the medical cannabis program as to whether Delta-8 should be allowed. And I don't think the Department of Agriculture has a clear stance on that. We're definitely open to direction from the product board as well as the Department of Health. For the time being, we've tried to put some steps in place to prevent some of the worst side effects from these products, especially performing all the required testing that's normally done for medical cannabis products on these, including residual solvents. And we also have a single quad mass spec that we run all of these concentrate oils that are being produced in the state on to make sure that it really is mostly Delta-8 and not a bunch of other stuff. So we do have purity standards for the oil that's being produced, which is at 95% plus a margin of error on there. And we're trying to get standards for the other analogs, but there's not a lot of those standards available right now. We do have standards for Delta-8, but for THCO and some of these more exotic ones, we just don't have the ability to get those standards. HHC is another one that's really on our radar right now.
Thank you. Dr. Viner, I think you've been waiting patiently. Let's turn to you.
Quick question. I think that Delta-8 brings to a head the need for both the consumer and the physician or equivalent prescriber to have measurements, have the dose listed on the product. I don't understand why we only use CBD and THC. Let's say you take an extract, it's 772 milligrams of THC in a gram, but the THCV, say, goes from 3 milligrams, that's a very small amount, but that's useful because if the next extract has 7 milligrams of THCV, again, a small number, you're using a complete inverse agonist. You're shutting off the CB receptors because it's a strong it's an inverse agonist, THCV. So how could somebody recommend an extract without knowing what the heck's in it? And the small numbers for the minor cannabinoids are even more important than the large milligrams for the major phytocannabinoids when you're dealing with the plant product. So I think Utah's unique because they have a medical cannabis pharmacy. So they should be, it should be a no-brainer to have a barcode on every product or whatever method you want, and to at least let the prescriber and the patient know what the heck they're taking. And for example, so in conclusion, for Delta-8, if you just list that it's really, really, really low, then you know it's from the plant. It's not been made by sulfuric acid at 100 times the strength. That should be a red flag. So it's time that we set measurements and dosing standards, in my view. And thank you.
Thank you for that input. Let's see, any other board members want to have some thoughts they'd like to share with regards to where we go forward with this issue as a board? Okay. Well, I'm going to say something that'll probably be viewed as a bit, I don't know, controversial, at least maybe rankle a little bit. But, you know, from the standpoint of products that are being recommended and used purportedly to improve health. I mean, we're not, you know, we're not in the business, if you will, and forgive the term business, to hurt people or to have people commit self-harm knowingly. that's simply not the intent of this program. So the question is, what can predictably improve health or at least not cause harm? So the sort of the least standard would be not causing harm predictably, and the best standard would be a tight covalent bond between mechanism of action and physiological or pharmacophysiological effect. I think that it's, maybe here's an inflammatory word, pretentious for any Utah cannabis program pharmacist, in the absence of knowing in great detail the patient with whom they're providing counseling, what drugs are on for what purposes, what their family and social context is, how responsibly they will be adhere to any course of therapy, which is the same standard we would hold a physician to in an evaluation and counseling about drug therapy for a condition, to then be making claims about a pharmacological agent, in this case a cannabinoid, whether it's Delta 8 or any other analog, where there is absolutely no good scientific basis and understanding of that effect, given the myriad conditions and situations that their patients face, other than the basic pharmacology, which we do understand pretty well, as Dr. Russo pointed out. So, if this is simply a gaming the system in order to make money, that's not the intent of the program. If it's allowing people to make choices, informed choices about their own health, and not having excessive government control on people's lives and choices, as long as they're not harming others, that's not also exactly what the program is about, but it's more like that than the other. If it's about getting enough experience and making up for the fact, and I'd like to see some positive head nods on this, that we're probably 50 years in arrears in understanding and good evidence-based approaches to understanding the potential value of single or multiple cannabinoid products combined with other constituents found in cannabis, including terpenes and flavonoids, et cetera. Yeah, we are way behind the curve, largely because of a regulatory environment that prohibited the kind of research and evaluation studies that all other pharmaceutical agents had. That doesn't mean that we end up without serious and significant public health problems. We've had robust research with regards to opioids, and look at the circumstances and situations we find ourselves in nonetheless. So we can only control what we can control. But one of the things we do have an ability to control within our program is, as was mentioned maybe by Dr. Viner, defining exactly what is in the products that people are taking to the extent we can within the cost structure, because we can't do anything and everything. We don't have unlimited resources. But we can in fact make sure that there's relative purity, that we're not exposing people to toxic substances, heavy metals, volatiles, et cetera. And that's Dr. Forsyth's role. Then the question is, how many degrees of freedom does the population of the state that avidly wanted a medical program for cannabis with medical intent, and a legislature that wanted that to go forward in a fashion that would at least be modestly scientifically driven. I'll use those qualifiers, and that we could actually learn from our experience. Not that we're doing a big research experiment, but that we're wanting to learn from the experience so that we can get better and better at predicting who might benefit from what, rather than just throwing darts at a wall and hoping that one of them hits a target.
Can I just
there's the bounds of where we stand. And I think that the only thing we can report out right now in my summary from this discussion and the inputs, as well as the literature that exists, is we really cannot make a positive recommendation to the legislature that we have an ample body of evidence that we believe Delta 8 THC as a derivative or synthetic, and there's arguments about what that means and what those words mean, but that converting CBD through an acid wash and then creating fuel, pharmaceutical grade delta 8 THC, we don't have adequate evidence and insight into how that's going to affect people's health or harms that it might cause. So we cannot put forward a proactive statement to that nature, which ultimately leaves this to the political process of what the allowances and the degrees of freedom within the allowances of these sorts of products might be. As a physician, I just gotta say it, or scientist, I'm not horribly comfortable with politics driving how the practice of medicine on an individual patient basis. On the other hand, that's where we stand. That's the reality. We've got some time. We can discuss that for the next 10, 15 minutes if you'd like, or accept the fact that this is sort of the state of the art. And then those of you who have other roles to play as either advocates or in state regulatory roles, go forward with your processes and to create the influence you and the outcomes you'd like to see.
Yeah, I appreciate that, Perry. And I would add that, what I've seen in the years that I've been on this committee is it's a political process that is a big factor in how this goes, and perhaps that should be so, but it's also I'm just looking at the most recent report on this program. It's an entrepreneurial free market issue. And we don't know the outcomes of, what benefits to our citizens the medical program has brought. We don't know that yet. We're trying to ascertain that. Did health improve? Did functionality improve? Did we get more addiction than we intended? Did we get more pediatric exposures than we hoped for? We don't know. What we do know is that this program has made a lot of people very wealthy. We can see the numbers. It's a great business opportunity for people. And I think I just see that at times it's discouraging. We want access to cannabis. We want government out of our lives. Yet we wanted a medical program that had an advisory board. I would say the politicians wanted that. The citizens didn't. They just wanted access to marijuana. They didn't want all the accoutrements and limitations that it seems to me we are constantly throwing, because that's our job. We're physicians, we're scientists. We have no monetary gain here. We are giving our time to weigh in, and yet the program plows forward, and it's baffling to me. It's hard to kind of find what our role really is, given what you've articulated. And I think it was clearer when we were going through, these predetermined conditions that others had chosen. And we went through those, that we can operate in that regard. And we made recommendations, none of which were valued or followed. And we'll continue to do that, but we're just doctors and scientists and people who have no stake in the market here. And I think that is what it is, and it may not be welcomed by a lot of people who participate in these meetings or who participate in the program or could benefit potentially from the program. And so I think I appreciate that framework. I think it's important to say that and speak of what our limitations are clearly. So thank you for that, Perry.
Thank you. Ed, I think you had a comment as well.
Good. Just a few questions. Right now, I think the law requires the dispenser or the pharmacies to label the product with the content of THC and CBD. And I think, Dr. Russo and I think Brandon's Forsyth has made some comments too here. I'm not exactly sure who else made the comments, but the certificate of analysis idea, I think, needs to be explored a little further. Meaning that we actually, so the pharmacist who's helping give some guidance to the patient, oftentimes, and the healthcare provider, the qualified, medical provider, they need to understand what they're doing too. And if there's a possibility that we're dispensing products that are contaminated or whatever, have other things in besides THC and CBD, I think the pharmacist needs to know that as well as the healthcare provider, as well as the patient. And I just think, I guess the question is, what does it cost to do an actual certificate of analysis versus just the THC CBD ratio? And Brandon, maybe you can help us with this. I don't know if you know what it costs to do the analysis, but to me, it seems like that's something we should be doing a batch analysis, at least on products that are other things besides just the flower. I mean, the flower is a little more simple that way, but when you're combining, hemp extracts and other things together with cannabis, cannabis extracts, you're trying to figure out what's in it. Right now, all we really know, as far as I'm aware, is it's THC CBD, ratio, right?
No, that's not the case. We actually do testing for 12 different cannabinoids in every product that's produced in Utah. And that is all available on the COA that we produce, and as well as the other outside.
Is it on the
labs.
label though? Is it on the actual label on the package or not?
It's available. I don't know that, I don't get involved in the labeling, but it should be available to the consumers and the pharmacists. It's uploaded into MJ Freeway, the track and trace system. And so there is an ability for them to find it. And I like the idea, and I believe it's a requirement. I don't know how strictly it's being followed, that anything that contains a synthetic or derived cannabinoid, whatever you want to call them, has to have that clearly put on the label as well.
I think that's someplace we can at least start, because I think that, right now, I don't know if the pharmacists have this information. I don't know if it's easily accessible to the patients or the healthcare providers that are engaged in this treatment. I'm not aware that it is. And I don't find this information. I've had a hard time finding out what was actually in the product that the patients use. They bring it in the office and they show it to me, and I can't tell what's in it, quite honestly. So I don't know what to tell them. I have no way of saying, okay, I have no way of learning from my own experience, my own clinical experience, taking care of the patient. And so I kind of, operate in the dark because of that. And the pharmacists, I think they have a lot more, and I know they have a lot more experience than I have in this realm, but my concern is it's important for everybody that's involved in this to learn as much as they can going forward. And some of that's going to be learned by just clinical experience. But if you don't know what you're doing, you're not going to be able to make any reasonable conclusions from what you're seeing. That's my biggest concern. So I don't know if we can go forward and try to make the labeling through the legislature or whatever, try to make it a strong requirement for the label to be on the product. I don't know if that's possible or not. Richard, maybe you can help with that too. I don't know.
Yeah, so the law requires that there be a label placed by the processor on every product that includes a list of the ingredients. Now, there's, I think, some discretion on the level of detail. Cody can correct me if I'm wrong. There's I think varying levels of detail of the ingredients, like how if there's a very minor amount of a certain compound, I don't think it shows up on the label, but the primary ingredients of that product do always show up on the label. And so the patient would know either by milligram or milliliter or percentage how much of the specific compound is in that particular product. It's always an estimate when it comes to flower, just because of the fact that of how they're structured and everything. And access to the certificate of analysis, I think, is there's room for improvement to get access to it. It is accessible, and I think Department of Agriculture could go into more detail about that, how one would go about tracking down the certificate of analysis specifically related to a product that they purchased. I think that's worth evaluating more, is ensuring that we make those more accessible. But on every product, there is a label, and you can track it back to a specific batch, and you'd be able to see the primary ingredients. Does that, Dr. Fine, am I able to send that over to Department of Ag, and maybe Cody James can address that really quick?
You bet. Cody?
Yep, thank you. Cody James, I'm the manager of the Industrial Hemp and Medical Cannabis Program, the regulatory side here at the Department of Agriculture. And as Richard said, there's actually several different aspects that go on to the the label. I can list all those out if you'd like, but first and foremost, I could say that it does require the cannabinoid profile to be on there. I noticed that there was one comment that said there's not all 12 cannabinoids that may be listed sometimes, but they are required, whatever is found in testing, to put on that label there. So if there's stuff that is in such a small amount that our labs are not being able to pick those up at a measurable quantity, they may not be on there. But if it's in there and measured for, then it does need to be on that label, along with the THC in milligrams, a list of ingredients, and each major food allergen if that's a situation, batch numbers and the date of final testing, and the date that it was packaged, as well as when it was harvested. So there's a list of about several different aspects. But as far as cannabinoids, anything that is tested for, of those 12, as Dr. Forsyth mentioned, that are found to be in there, should be listed on that
Okay.
label.
All right.
Thank you, Cody.
Just real
I'm
quick,
gonna-
additionally, any that are claimed to be on there have to be tested for. So if it says it has HHC in there, then it would need to be tested for that before it could get registered and sent to market.
Brandon, what about certificates of analysis? How accessible are those?
I'm not the person to ask on that. I produce
Okay.
them. I don't know. I don't distribute them other than to the individual processors and the program, obviously.
Yeah.
Well, I would say that there is a gap between what might be out there and what is available to us as professionals, if you will, health professionals, and the public, and perhaps even to the pharmacists in terms of what's stated on the websites, what's stated on the products, what's in their inventory, because there's very little information and very hard to
I believe the
access.
pharmacists do have full access to
They have access.
the
I
COAs,
have no-
don't they, Rich?
Well, and I'm not sure if there's if they share it, if they've, if they actually, go back and access. But I'd say that there's, I'm going to sort of make a statement. I'd actually like Dr. Russo to comment on my comment, with his experience and understanding of this, that at the very least, we want to understand and know, and that they're good, my understanding, there's good processes in place within the Utah program, from a laboratory standpoint, to put in sort of best practices to ensure absence of toxic substance or contaminants to a certain level, as has been stated. That's sort of step one. Step two is, okay, you don't have impurities from the standpoint of unwanted substances that have nothing to do with the cannabis plant. Now the question is, what's actually in the extract, and of the hundreds of things that are in there, what is meaningful? What are the constituents that are of a level that might have a physiological effect in an individual? What are the constituents that might have additive, synergistic, or what's sort of in common parlance, entourage effect, therapeutic benefits? What might have countervailing effects, meaning competitive and potentially partial or actually antagonistic effects? And what are cannabinoid and non-cannabinoid constituents that might have positive or negative effects? And quite frankly, the statement I'm going to make, which I want to comment on from Dr. Russo, is we really don't know with any great degree of certainty, other than from a few well-designed studies that give us insight into pharmacokinetic, pharmacodynamic relationships with right now a few at the most of the cannabinoids, either individually or potentially combined, and only for a very narrow range of conditions. And most notably from Dr. Russo's work in epilepsy, childhood epilepsy. So, and then there are a few others. So so at the very least, we want to understand purity and processing. At the next level, we want to understand what the constituents are and what in measurable amounts. But anybody sitting there reading that label, from a pharmacist to a patient to a professional, cannot, with intellectual honesty, look somebody in the eye and say, if I give this to you and you take it as recommended, this is likely what's going to happen to you. We just don't know. So safety first, and then hopefully some kind of therapeutic benefit over the course of time. But we've got a long way to go to understand these PK/PD relationships that we've been sort of alluding to here. I'll stop there. And Ethan, what would you recommend to our board going forward with your background in all of this as a sort of a next step to help us organize ourselves in the most both safety and therapeutic positive benefit and outcomes or intermediary outcomes we can derive over the next, say, year or two?
Sure. Well, I agree with basically about everything you've said. Safety first. So it should be a requirement that there not be residual solvents, molds, etc., in the material that's being provided. Second is what is in it. And there are ways of portraying this in an accessible form. And I'm going to hold up and hope that you can see this a little bit. This is a thing called Phytofax. It was developed by Mark Lewis, my former colleague. What it does is show the specific amounts of measurable cannabinoids and the terpenoid profile that we see on the bottom. That is coupled with reactions by actual consumers, whether it be energy, comfort, etc. So yeah, everybody's different. We don't know someone's underlying tolerance or endocannabinoid tone, their set or setting, but within reason, if a few hundred people have taken this and reported these kinds of effects, it may offer some direction about what has happened to other people. And again, it is true to say that we don't know how all these things combine, but some of us know a good bit. And again, the number one is keeping out the bad stuff that we know to be toxic. Fortunately, in cannabis, there are very few of the components that have a lot of inherent toxicity. The most obvious is THC, but only in amounts that are too great for that individual. So, in terms of what I'd recommend, I think that the board could be proactive in trying to encourage these kinds of standards so that the consumer has the best available information on safety and components. And again, hopefully coupled with a practitioner that can help guide them as to what might be helpful for their particular condition.
Thank you. That's, I think, some good conclusory concluding comments. Let me just check the board here. Yeah, I think that another sort of final comment for this purpose of this discussion is that there's a big difference between advising with aspirational hopes and trying to limit harm and actually making claims. Sure. There is a legal definition of what a claim is with regards to a product, whether it's a nutraceutical or a pharmaceutical, and those standards actually are upheld with regulatory bodies to the point where if you're caught making claims and you're not supposed to be, you can actually, there's civil penalties and up through potentially criminal penalties. So what's so interesting about or at least, and I'll limit on my comments to the Utah program, is I think, certainly I've been exposed to individuals who are working within this larger sphere of the program who are making claims all the time with very little evidence-based from the standpoint of the kind of evidence we're talking about to substantiate those, no less having gone through the excruciatingly difficult processes that our regulatory structure requires for claims. Dr. Russo, certainly in his work and in pharmaceutical development, knows how strenuous and costly that can be. And whether that's good, bad, or otherwise, it is the way we're currently structured. And the purpose is to protect the public from unwitting harm from what was classically called snake oil salesmen, where it could make claims about anything. So that's sort of the structure of things. And I would hope that we could arrive at a place where we could clearly differentiate between claims versus aspirational hopes. And we could get to and move towards the place where we could actually make claims because we have an adequate knowledge base to do that. And I don't think if this program lives, the polarity of it is largely political. We won't get there because it's not structured to do that. If we are overly scientific, then we will, it'll be decades before we get to that point. So we have to create sort of this hybrid model, which I think we're trying to do here in Utah, with input by really thoughtful people, all of whom I think are, many of whom are on this call, where we balance these issues and then cross our fingers and hope for the best that the legislature is inspired by some sort of wisdom rather than simply reaction on the basis of running out of time or conflict, special interests largely driven by financial agencies. That I think would be disastrous. And so we're trying to avoid that. That stated, I think my hackles have been raised, and why I'm speaking in this manner is because I think we've moved too quickly towards cavalierly allowing certain individuals to make claims and not holding them accountable for those claims. And we don't know what the consequences of that are. With that said, I give a counterpoint if anybody would like to. And then if not, I'm going to bring the meeting to a close with, again, great appreciation to all of you for weighing in, especially those who have given us their waived their consultation fees from afar for aiding us in hopefully being a responsive and responsible board with a stated intent that we have.
Dr. Fine, if I could just share a takeaway, I think is one item I'd like to evaluate a little bit more is the accessibility to certificates of analysis. That came up in the comments of those that commented, and also obviously it was a discussion point. And I'd like to evaluate the feasibility of that, just making it something that would be more accessible to patients if they choose to. Some patients, this is something that is very valuable to them. Others, they may not think it's valuable, but it should be. So I feel like we can take a look at that and provide some ideas to the board about how that might be done. I also, at the very least, I would anticipate that during this legislative session, that there will be, at the very least, a requirement that information about a synthetic cannabinoid shows up on a label. So I think that's something that we will see at the very least be required. And we could see additional things, but that is something that I think would be reasonable that we may see happen to better educate patients about the products that are synthetically created when they purchase it.
Good. All right, well, we have, I think, plenty to discuss in January and mull over in between. Melanie, thank you for taking detailed notes so we can cull through those and create an agenda that focuses on these. And then we will, by maintaining our relationship as or our position as a publicly open forum here, you will all be well aware of and welcome to participate in these discussions that we have today. We do have a means of directing our recommendations through to the Health and Human Services Committee. We've got a conduit, a formal conduit for doing so. So as we sort of solidify our thoughts and all, I think that we'll start off the new year with some recommendations based upon some of this discussions and filter them through or direct them through that conduit. Thank you very much. And just mostly great health to all of you. Stay well, best to you and yours, and have a wonderful holiday. And some of you will, well, the board will see you in January, and and look forward to our next level discussion. Thanks one and all. Bye-bye.
Thanks, Perry.